Now, here's the big one, congestive heart failure. This is dysfunction with our cardiac pump. It leads to heart congestion, a decrease in cardiac output, and therefore low perfusion to the body. There can be systolic or diastolic dysfunction. In systolic dysfunction, where we have a reduction in ejection fraction, we will see an increase in our end diastolic volume, our increase in the amount of blood that's essentially stuck in our heart, right? We're having this backflow of blood. And therefore, we also see decreased contractility. So we have blood stuck around. We can't push it out. So our ejection fraction is reduced. Versus a diastolic dysfunction, we have a preserved ejection fraction. We have a normal end diastolic volume, but we have just decreased compliance. The heart can't expand. It can't take in more blood, and therefore you'll have increased end diastolic pressure. Now, inciting events, etiology, oftentimes an injury or a kind of chronic pressure volume overload leads to this reduction in cardiac output. The heart has really helpful compensatory mechanisms that initially it's helpful for the body, but over time, it actually ends up harming itself. So the Frank-Starling mechanism, remember, it's what goes into the heart must come out of the heart. So it allows for the heart to um, allow for an increased amount of preload, blood coming into the heart, which allows for a stretch in the myocardium. And then if the myocardium's stretched, it's going to have an increase in contractility. And that's short term. Fine in the short term, bad in the long term. The ROS will activate because the kidneys will sense over time, like when this increased contractility starts to decrease, the kidneys will sense that there's a decrease in perfusion. They then kick off the ROS. Renin, getting us to angiotensin 2, getting us to aldosterone, increasing sodium and water retention, increasing blood volume, therefore increasing blood pressure. We also have our sympathetic nervous system that becomes activated that's going to increase our heart rate to try to make up for this perfusion loss, increase our contractility, and vasoconstrict, making it a smaller tube to try to push this fluid through. And then we start to see in response to that, our ventricles remodel. Our myocytes get larger, hypertrophy, because they're having to work harder to get blood through the heart than they normally would have to. And the chamber is going to start to dilate over time because the heart needs to accommodate more and more blood that's either being left behind, can't get kicked out, or that's kind of coming back in due to this volume overload. Over time, these compensatory mechanisms lead to an inadequate cardiac output, congestion of fluid throughout the body, and then end organ hypoperfusion, lack of organ perfusion. As we age, the risk increases. Kind of a lot of your classic conditions of the heart are listed here as risk factors, plus tobacco and obesity. Issues with valves and hypervolemic states also can increase risk of CHF. Typically, you're seeing shortness of breath, trouble orthopnea, trouble laying flat, fatigue, exertional issues. Some interesting signs you could see, pitting edema or JVD, where you have that distension in your jugular vein, or an S3 heart sound, an extra, what would that be? Kentucky, yeah, the E on the Kentucky, and a sound after the dub of lub dub, essentially. And then rails or crackles in the chest. Looking at the differences between the hearts, the sides of the heart, right-sided heart failure, oftentimes we call this like cor pulmonale if it's true isolated right-sided heart failure, and this is often due to pulmonary etiologies, like pulmonary hypertension, for instance. Oftentimes, though, we see it most commonly caused from a left-sided CHF, left leading to right progression. And then there's some other etiologies here. And here's kind of what your symptoms look like. You have a backflow of fluid that's backing up from the right side of the heart. So you'll see congestive hepatomegaly as some kind of clinical signs. This is due to increased central venous pressure that leads to an increased resistance to portal flow, and then hit the hepatic cells, the hepatocytes, the liver becomes engorged. The liver can look nutmeg in color, which is more of a mottled appearance on a gross exam, with these altered red, congested with blood and pale areas due to like, ischemia. Can see JVD because increased venous pressure causes backflow into the jugular veins because there's not enough blood getting through the system. And then peripheral edema because increased venous pressure leads to some fluid transudation to the tissues, fluid leaving the different vessels, getting into the tissues and then sticking around. Risk factors, really left-sided. CHF is the most common risk factor for right-sided. Pulmonary hypertension is another one, or any like other lung disease. Complications wise, I already listed a couple of them. Ascites, where you have edema on the stomach. Pleural effusion, where you essentially have fluid that's into the like pleural space, which can affect breathing. Decreased cardiac output put forward can make it so that exercise you're intolerant to, and ultimately right ventricular dilation, and therefore then regurgitation through the tricuspid valve. Contrast that to left-sided CHF. This is oftentimes more associated with an ischemic presentation or a valvular issue on the left side of the heart. Complications, AFib, and stroke are more common complications, and here are some of the symptoms you can see. Common pathogenesis, clinical signs, pathophysiology, orthopnea, you have shortness of breath when lying flat. This is because increased venous return redistributes blood and worsens the vascular congestion in the pulmonary trees. It feels like you're literally drowning in your own blood and fluid. Along with that, you could have paroxysmal nocturnal dyspnea where you wake up gasping for air. And this is due to increased venous return from that redistributed blood and then reabsorption of peripheral edema when you're lying flat. So more fluids gone into the system. Pulmonary edema is often due to increased pulmonary venous pressure, leading to distension and then leakage of fluid into alveoli, that sensation of drowning on your own kind of blood plasma. And then HF cells, which are hemosiderin-laden macrophages. These are macrophages that eat red blood cells that have leaked into the alveoli, and we see this in pulmonary edema. And so then we can have these macrophages that are just kind of have these hemosiderin, uh, these components of a red blood cell trapped within them. Some interesting labs to kind of finish up on. This is not a diagnostic test, but sometimes they will ask about um, physiologically or pathophysiologically, like what are these specific labs potentially involved with? So troponin INT, these are proteins that can be released from damaged heart muscle cells. We see them elevated in NSTEMI and STEMIs, not in angina. They typically rise 3 to 6 hours after the ischemic event, peak within a day, and can remain elevated within 7 to 10. And it's really suggestive of a myocardial injury. B-type natriuretic peptide is different than A-trial natriuretic peptide. This is released by ventricular myocytes, and it's due to wall stress or volume overload. So we see this in CHF, and the higher level of BNP, the worse the heart failure is. You also can see it in pulmonary hypertension. And then lipid panel, you have your total cholesterol, your low density, your high density lipoproteins, and your triglycerides. Both elevated LDL and low HDL can contribute to atherosclerosis, which can contribute to other conditions. It's really used for cardiovascular risk, and there can be some target LDLs that vary based off of the risk category. That's your end of your kind of down and dirty first portion of cardiac path. We will be going over some further cardiovascular pathologies when we both meet together, as well as in the upcoming weeks and sessions. But we cannot go through them all. So it's important that you go through those 5 components: pathophysiology, risk factors, etiology, clinical presentation, and prognosis.